Welcome to the Ordinary Doula Podcast with Angie Rozier, hosted by Birth Learning, where we help prepare folks for labor and birth with expertise coming from 20 years of experience in a busy doula practice, helping thousands of people prepare for labor, providing essential knowledge and tools for positive and empowering birth experiences.
Hello and welcome to the Ordinary Doula Podcast. I am your host, Angie Rozier, and I am glad to be with you here today. So our topic today is going to be about breech babies and breech deliveries. I've had a couple interesting and different from each other breech deliveries with my clients in the last couple months. So this has been on my mind a little bit, and it's something that I think, it's a lot of doulas run across for sure, and it's kind of an interesting phenomenon. So I'm going to give a couple little facts about the breech position. Breech means the baby's head is not down, right? It's not heading out, the head is up. And when the head is up, there's a variety of positions, even among breech, that the baby can be in. We call a head down baby a vertex baby. We call a head up baby a breech baby, so the head is up, not down. There are a variety of positions. Even among that, there are frank breech, which the bum, like the baby, is totally folded in half at the hips, and so their bum is presenting first. There's babies that are footling breech, where there's one's called complete breech. They're kind of sitting crisscross applesauce in the pelvis, or footling breech, one foot maybe lower than the other. But the point is their head is kind of headed in the wrong direction. It's interesting to know about 3 to 4% of pregnancies, at the end of pregnancy, we're talking, 36 weeks and beyond, about 3 to 4% of babies are going to be in a breech position. So it's, something you run into. You may experience it, or you may know someone who experienced that. It's not terribly uncommon, but 3 to 4% we're gonna see it. This can be due to a lot of, whenever something's going on, I always just instinctively ask, like, why why are babies breech? And there's a lot of different reasons for that, but it's hard to pinpoint the exact reason or reasons why. It could be a lot of fluid or a little bit of fluid. Those have different medical terms. So, if you're hearing medical terms, hydramnios, and then you have high or low fluid, that can cause a baby to have the ability to do a whole lot of moving and maybe be head up. Other reasons could be the shape of the uterus. Sometimes the shape of the uterus encourages the baby to be that way. It could have to do with the shape of the pelvis. It could be where the cord is placed, or the placenta. If it's a low-lying placenta in the front, sometimes we have an increased likelihood of that breech position. But sometimes the cord kind of acts as a tangle, and based on whatever the baby's movements are during pregnancy, sometimes the baby gets tangled in the cord and kind of gets tied up in a breech position. Sometimes people who have one breech baby might have subsequent breech babies. So there's a few different reasons. One of them even talks about stress, like the element of stress. And I have a client who anecdotally for years has said she believes that breech babies, there's an emotional component to breech babies. So this theory, and this does have some research and study behind it, that the increased likelihood of stress, physical, emotional, mental stress, can tighten the lower segment of the abdomen or of the uterus, and so the baby's not comfortable like going down. It's kind of tight up there, tight down there, so that they kind of end up head up. So that's funny, end up head up. So there's several reasons. None of them are super linear, obvious, and we don't always know why babies are breech, but we have by 36, 37 weeks, about 3 to 4% of babies remain breech. There are several different ways to try to turn a breech baby. Maybe you've heard of these. Some of them are very evidence-based. Some of them are not. None of them are 100% effective. None of them are even 50% effective sometimes. Sometimes we're hoping for 50%. So some of those efforts to turn a baby, some of these are very old practices. One of them is, we call like the ironing board trick. That goes by different names sometimes, but kind of an inversion where you take an ironing board, just because most people have one, it's pretty sturdy, and you put the ironing board, it's flat, right? The legs aren't up, it's flattened, but you put the ironing board up on a couch, and then the pregnant person lies so that their head is near the floor. Their feet, hips are up on the couch kind of, but on the ironing board holding them. And spend, there's different recommendations, but spend several minutes, 15, 20 minutes in that position several times a day. So this is an effort with gravity to help that baby to turn. And pregnant people, no people really spend their time upside down or inverted for very long, but this is an effort to try to get babies to turn positionally. Another one is kind of doing an inversion, a deep, exaggerated inversion. And you'd want help in all of these interesting maneuvers. You want somebody there to support you as you're getting in and out of these positions with the ironing board and with this deep inversion where on a couch, hopefully it's not a super high up couch, but on a couch, like you're kneeling on the couch and you're leaning down onto the floor beneath the couch. Super uncomfortable, especially with a baby belly right in between your legs. And that like is a deep inversion, again, with gravity and position to help get babies to turn. Spending time in water. Some people have had success with this, like not just a bathtub water, but like swimming pool water and a large body of water or a large amount of water. And maybe do headstands, like do some flips, do some inversions in the water. Some people have had luck doing that, getting a baby to switch. Other ones can be sensory efforts, and that can be encouraging babies to turn using senses such as light, temperature, sound. So if you put, go toward the light baby. So we want to put a light down towards the bottom of the abdomen, where of course their eyes are going to sense the light. Eyes are at the top. If they're breech, hopefully they're going to be curious. They can sense light by this age, 36, 37 weeks, and hopefully we'll kind of get curious and go toward that light. Evidence-based? No. Can it work? Possibly. Same thing with temperature. Babies don't like cold, so a recommendation could be to put cold on where you don't want the baby's head to be, something that the baby can retract from or go away from. So that might be a little cold pack on the top of the belly where the baby's head is, and the baby might move away from that. It'd be funny to have a bag of peas frozen peas sitting on top of your belly for a while. Also sound, playing some, I've seen reports of playing wild, crazy music low on the abdomen where you want the baby to go, or kind, sweet, tender, relaxing music, whatever it is you anticipate that baby being drawn to. So there's some sensory efforts. There's some slightly more scientific efforts, such as moxibustion, which is an Eastern medicine effort with it have a little like an incense stick, it looks almost like, and between pinky toes, and the thought is that helps turn on some hormones that during pregnancy related that may help a baby to turn. Another effort is a chiropractic adjustment, keeping the pelvis nice and aligned, and sometimes babies are in a breech position because the uterus is torqued based on tightness of muscles or fascia or tendons. Ligaments, the round ligament has a lot to do with the how the baby's sitting in the pelvis, so making sure those are released and the pelvis is lined up. Sometimes once we get that pelvis lined up with a chiropractic adjustment, the uterus can relax as a muscle and it's not holding the baby tight in whatever position the baby might be if it's in a breech position. The Webster technique is a technique that chiropractors use specifically to help babies turn. I have had clients use this several times with no luck. I've had clients use it once, and on the way to the parking lot after the chiropractic visit, they feel a pretty incredible turning. So those are some other efforts to try to turn babies. And then we're kind of moving up the order of invasiveness, I guess you could call it. Although ironing boards and deep inversions they feel invasive to your brain after you do that for a little bit while. Another one that the medical community uses is called an ECV. That stands for external cephalic version. So external, of course, on the outside, cephalic is the head, the baby's head, version is a move. Now, I cannot tell you how many of my clients, it's so dang cute over the years, have called it an aversion. They're going to have an aversion. I'm going to the hospital for an aversion. So an aversion is a strong dislike towards something, and it just cute as can be and cracks me up when people say I'm having an aversion today at 7 a.m. at the hospital or whatever. So it's just a version. Aversion is moving something. So ECV, external cephalic version. This is some maneuvers that care providers do. OBs do this, midwives do this, and or assist with it, have assistance. This may be discouraging, but the evidence does tell us it has about a 50% chance of working. So it's not like, this is kind of the last thing to try, and it has the best chance, but it's not a great chance, but about a 50% chance of an ECV working. So ECV is done in a hospital. You work with your provider on when this can be done. There's different schools of thought. Do we do it at 36 weeks, 37 weeks, 38 weeks? Babies are smaller at 36 weeks. The likelihood they may turn is better. But if things don't go well and we have to deliver that day or quickly, we want a baby maybe to be a little bit older. Like, it's kind of tricky. So work with your care provider, get all the evidence, get all your questions answered as you make a decision. If you are faced with an ECV, a version, not an aversion, maybe you have an aversion to aversion, but kind of get some, good talking points done with your provider if that's kind of what you're looking at. So that's done in a hospital setting. I've been with many clients during that. Sometimes it's done in a labor and delivery room. Sometimes it's done in a triage room. Sometimes it's done in a labor and delivery room near the OR. But the person is given, usually they're given a muscle relaxer. Usually it's tributaline. They get you kind of prepped. They lube up the belly pretty good. I have had people get fentanyl for this because it is uncomfortable. I've had people get epidurals for this. Like, they'll get an epidural so that because the uterus, once you crink on it like they're going to in a version, it just kind of stimulates it, right? And so it wants to respond by contracting, and we're trying to move the baby in it. So when it contracts and gets super hard, it's difficult. So they may do take some efforts to soften up that muscle of the uterus. But this is done usually with 4 hands. Baby's heart rate is being monitored. And it's uncomfortable. I guess that's an understatement to say that it's uncomfortable. I've had the sweetest, kindest clients say, I just wanted to punch them. Others have said, man, that is intense. That is so intense. Because your body wants to respond, right? It's very uncomfortable. So 4 hands are on, and I've seen the providers doing it. Like, they are hot and heavy sweating by the end sometimes. Not that it takes very long, but it's a lot of effort for them. So they feel where the baby is. They typically like the baby to dive forward, so follow their face kind of a thing. So they're going to generally, you have 2 hands on top, 2 on bottom. So lifting the butt, sometimes I have to lift that cute little bum out of the pelvis a little bit, help that head to dive forward so they're on the top of the uterus, on the top of the fundus. From the outside, encouraging that baby to take a dive, lifting it out, so having the butt go to the side and then up and the head go down. So kind of doing a little twist and a turn. Remember, 50% effectiveness rate, 50% chance of it working. So can be discouraging going into that, but it is definitely something to try. Something to note with a version, the hospital staff is ready to deliver baby quickly if needed. They'll generally do this with an OR already, right? So they know that they have staffing and that an operating room is ready if things don't go well. If the baby doesn't respond well, they're going to kind of be ready to deliver a baby pretty quickly. And interesting to know that this is safe for VBACs. If you're somebody who has had a prior cesarean, so you have or uterine surgery of any kind, you have a scar on your uterus, studies have shown that it is safe for people to have a version, an external cephalic version, even if they have had a prior C-section or abdominal surgery on their uterus. So that said, those are ways to help turn a breech baby. I want to go a little bit into the history of this because in mainstream, right, in our mainstream medical world, a breech baby most often means a cesarean delivery. If all the things we try, and really one of the best things to try is time. sometimes just relaxing about it, relaxing our hearts, our minds, our bodies, and giving that baby time, they can turn, right? At 37, 38, even 39 weeks. I had one client one time, tons of fluid. Her baby's, I think she was having her third or fourth baby, and she was very familiar with her body, and she could just sit in the tub, get her babies to turn head down on her own, just because she could kind of guide them down with, she had tons of fluid. Was very well aware of where her babies were, and her babies were turning up till the day of delivery. But that's a little less common. But for so many people, having a breech baby equals a C-section, right? So maybe you weren't wanting that, you weren't planning on that, and it feels like the choice is out of your hands. Sometimes when you look online, it kind of is interesting to me. Sometimes, a lot of the articles will say, yeah, try for a vaginal breech delivery. Really, that's pretty hard to get. Like, it's hard to find a provider who does that. And so let's talk about some of the reasons why. Years ago, I was doing a birth with one of my very favorite midwives. She's since retired, but she was incredible. And she was a nurse before she was a midwife. I don't remember the incidents of the delivery we were doing, the client that we were with, but we were talking about breech deliveries. And she said, 30 years ago when I was training to do this, so this probably would have been in the 90s, early 90s, maybe late 80s. She said, we did breech deliveries all the time. There would be like 5 a week. She was at a pretty busy hospital. She said we would have 5 a week. It was very common. Like it was nothing about it, right? It was okay, that baby was born breech, no big deal. You might speak to older women who are 60, 70, who, when they were having their babies, they had a breech delivery, and nobody knew it was breech until that baby was born, right? They're like, oh, look, cool, a breech delivery, no big deal. Whereas now, if that baby's breech, like, oh no, we can try these things, it probably won't work, let's just schedule a cesarean, is the theme of the day now. So let's understand that it used to be, this is like a generation ago, right? We have forgotten that this was normal. It is no longer normal, but it used to be normal. Doctors used to be trained in how to deliver breech babies because that's what they would do, right? Like they would have a certain percentage, 3 to 4% of all babies were born via, that breech position. And that's no longer the case anymore. So the craft, the art, the skill is kind of fading. Doctors aren't as adept at it. They're not practiced in it. They're not taught it very well, if at all, right? If at all, a lot of the training may just become from a video or something in medical school. So kind of interesting that it's just kind of a lost art. And part of what helped that become a lost art was a combination of things. But in 2000, there was a study called the term breech trial. And it was a study of a kind of a small number of people that came out in the year 2000. So we are about a generation ago, that said, we do not recommend, they tested, I think it was, don't quote me on this, but I think it was 100. I can't remember. I'm not even going to say the numbers because I don't remember them. They weren't crazy big numbers, but they tried, they followed the outcomes of some breech deliveries and some cesarean deliveries with breech babies, right? Vaginal breech and cesarean deliveries. And they came out with a study and pushed ACOG the next year to make a statement about it, that it would probably be better that breech babies were born by C-section. They could mitigate some risks. And today, 86%, I think that's a little low in my mind, 86% of babies who are breech are born by C-section. And kind of interesting that means there's 14% of babies being born breech. I want to know where, like in my experience throughout the country, unless it's out of hospital, there's not a whole lot of hospitals that will have you, let you deliver a breech baby. In the states that I've worked in, I can come up with like 2 doctors maybe in each state who aren't, it's not like they're close together or anything, that will consider doing a breech if everything's fine. So difficult to find a provider to do that. Also, at the time, C-section rates were on the rise. We know they've been around 32% or thereabouts for the same amount of time, interestingly enough, right? If we're going on over 20 years of that C-section rate in the United States hanging around that 32, 33%. which varies by state. And breech deliveries contribute to that, right? When we quit doing vaginal breech deliveries, which by and large were safe. And if you look at the actual numbers, yes, the risk is there. But this study came out and said if there's any risk at all, it's not worth taking, right? So kind of dive into what the risks are. It's kind of interesting to know what they are. And also at this time, if you look at the logistics, the bookkeeping, the scheduling of delivering a cesarean delivery with a breech baby, it's a lot easier. There was one doctor at this time that said, if you have a defendable way, a defendable option, why would you not do it? So what she was talking about, this doctor, and this was 25 years ago, said if you have a defendable in court, right, and if this becomes a litigious situation, you have a defendable option, why would you not use it? Why would you assume any risk at all? Any risk is too great a risk. So those risks include, risks to breech babies' deliveries include head entrapment, which is actually, if you look at the numbers, extremely rare. Prolapse cord, because those smaller parts of the body can be lower and they're not filling up the whole space, the lower uterine segment. And so a cord, if the water breaks, could come down by feet or knees or whatever. That's why the frank breech delivery, when the baby's just folded in half, the butt's coming first, that mimics the head as best as other part, the other better so than other parts of delivery. So just kind of interesting. And ACOG did make a statement shortly after that kind of shifted some policy. And over time, we don't even have doctors trained to do that anymore. There's a memoir that I have read several times and I absolutely love. It's called Listen to Me Good. It's about a midwife who delivered babies out of hospital, so home birth deliveries from the 1940s to the 1980s. She was in the Deep South. And it's fascinating to read. And one of my favorite parts is she delivered plenty of breech babies. They didn't scare her. She just, okay, this baby's breech, here we go. And this would scare, I think, even our most well-trained breech doctors who deliver breech deliveries today, which are far and few between. She said, my favorite kind of a breech is a footling breech because I can take that one foot back up, grab the other foot, and pull that baby out. Wow, that was pretty wild to me, but that was normal not that long ago. And she had a very good record. I think she did 3,000 deliveries over 40 years in Alabama and had not lost a baby. No, sorry, excuse me. She had never lost a mother, actually. There's a couple babies that had died in the course of her practice, but kind of interesting where we were and where we are now. So keep that in mind. Also, the time, the money, and the skill involved the skill set became low, and how to deliver breech babies. The time in the OR is short and the money in the OR is better. So you can see how it just kind of naturally went that way. So I guess the message I want to people to have here, and in the next episode, I'm going to give you 3, because I've attended, had some great breech deliveries lately. So I'm going to tell 3 little stories that are recent breech delivers for me. But I guess the point is to do your research and to find out what type of breech, if you find yourself with a breech baby, how can we encourage movement? What type of breech is it? What providers in your area? Get creative. Think outside the box. What providers might support that? And how do you feel about having a cesarean? So we know the risks of breech, and they can be low, but you know what? Cesareans have risks too, and they have great risks to mom and baby too. So we kind of weigh all the risks as we make a decision. Anyway, just kind of interesting. A little bit of history lesson here. Here's where we are today. We got to work with what we have. I'm not saying it's wrong. I'm saying it's interesting. Cannot tell you how many times my clients, breech, okay, we're having a cesarean delivery, That's pretty common. That's where we're at today. But there are those, and home birth midwives among them, which I will talk about a story in my next episode, that deliver breech babies, have trained to do it. Still, the training is out there. It's not in medical schools, but the training can be still had by those who want to. It's not a lost art all the way, right? It might be in our mainstream medical community. So listen to the next episode for some specific breech stories. Hopefully your baby is head down, keeps things easy for you, and it heads on out the way that makes it a little bit easier. So a little bit of tidbit facts there about the breechness of babies. Hope that helps or is interesting or gives you a little bit of background information on where we were and where we are now and how we got here. So as I wrap up today, as always, make a connection with someone, make a human connection with someone, and maybe it's digital. Reach out digitally by text, by messenger, by however you want. Reach out to somebody and just say, hey, been thinking about you. Hope you have a good one, and we will see you next time. Bye.
Thank you for listening to the Ordinary Doula podcast with Angie Rozier, hosted by Birth Learning. Episode credits will be in the show notes. Tune in next time as we continue to explore the many aspects of giving birth.